thank you everybody who is interested in hearing a little bit more about what education is available through the Jackson Laboratory. And I really, before we get into the content, I have obviously have a presentation and some interaction, but I really encourage this group to, use chat, and I will stop because I'm managing this myself. I will find times and remind myself to look at the chat and make sure that we're answering questions. Also, feel free to chime in. That's fine as well, because really what my goal here today is just to sort of talk through some of the resources that we've developed over the years, and to get some, and any feedback you have along the way is helpful. So I'm going to go ahead and get started. And I'll give you a little background for those of you that don't know the Jackson Laboratory about who we are and why I am here talking about education. So let me just check. Are you seeing my notes, or are you seeing what you're supposed? Thank you, Alyssa. So like I said, what I'm hoping to do today is just to provide you a little bit of insight, which many of the folks on the call will know about how genomics impacts us throughout our lifetimes, and tied to that, what educational resources specifically has the Jackson Laboratory developed, because we have quite a quite a library of resources. And then of course, there are many other resources that other groups have developed as well. So first, let me introduce myself. I'm Kate Reed. I have been working at the Jackson Laboratory as part of the clinical education program for about 8 years now. And really what our mission is to help connect clinicians to education around how to incorporate genetics into their practice. And specifically what we want to do is provide education that is very application oriented. So not what's coming, not what could be, not just to increase knowledge, but really try to help folks increase their skills around incorporating genetics that is ready for prime time. This is not a session that has CME or CEU credits associated, but I did just want to say that for those because laboratory is in our name, we have learned over the years that we need to just be very specific about it. So we do not sell tests to clinicians. The laboratory aspect, it has more to do with the research, and we also we have the component that does sell is it sells mice for researchers to do studies. We do have a CLIA lab, but it's a very small program mainly tied to our research. So we are not aiming to increase use of JAX or non-JAX products or services. So JAX is a nonprofit organization that emphasizes research and education to improve human health. The research aspect of things is quite broad. It focuses from everything from cancer to addiction to dementias, as well as computational biology. The JAX genomic the education component of JAX has been around for almost as long as the lab. It has a very rich history in, some of you may be aware, there's a summer student program where high school and undergrad students go and spend the summer in Maine doing research with our faculty. And now we have campuses also in Connecticut, primarily research, and then we have a production facility for the mice also in Sacramento. But our genomic education group has grown over the years. There's certainly courses and workshops that trains researchers in sort of cutting edge genomics. There are a number of programs for high school teachers to incorporate genetics and genomics into the classroom. And then of course, there's the clinical education program, which started 8 years ago, which is when I came on. And like I said, we are looking to help clinicians sort of where the rubber meets the road. So we have this great research facility, but we're really interested in providing education that is ready to be integrated. All of the education that we currently provide is free of charge. It is almost all of it has either CME, both CME and nursing continuing education credit involved. And I think we probably have one of the largest catalogs of resources specifically with genetic and education anywhere out there. Although, of course, we have a breadth, and there are definitely groups who have more depth in different areas than we do. So our goal is really just to get this education out there to people who can use it. And so that's really my goal, and the reason that I'm excited to talk with you today. But first, that's a lot about me. So what I'd like to do is kind of get a sense of who is on the call. Okay, which I'm not going to be able to do because I tried to log in with my phone earlier. And so now I have been inactivated from using my polls. So if you don't mind using chat instead, and just let me know where you're coming from. What is your background? Are you an individual, a family member who's impacted by a genetic or genomic disease? Are you a genetics clinician, non-genetics clinician? I'm just interested to see who I am talking to today. That is the one disadvantage of having having a larger group. So I see some cancer, some genetics clinicians. All right, a lot of genetics, and a family member, lab genetic counselor, a researcher at the NCI, geneticist. Great. Some mouse models that are using for in our lab that come from JAX. There are some interesting ones that JAX has, most certainly. Great research coordinator in cancer and a prospective genetic counseling student. Great. Well, family member, family advocate, wonderful. Well, it's really great to see who is interested in education, and I hope what I have to say to you today is helpful. So I want to continue a little bit more in terms of getting to know your thoughts. So because I'm going to be talking about the lifespan and where does genetics come into lifespan, I'd like to get your thoughts about at what point in life does genetics have the most impact? There is no right or wrong answer here. We're going to go through the whole thing, but I'm just curious to see where people are falling. And again, please use the chat. Neonatal, pediatrics, so childhood, before birth, childhood, adolescence, adult, senior, the whole lifespan, all of life, it depends. Yes. So you know where I'm going with this. And lived experience in family, as well as translation and charting the life course ambassador. Okay, depends on the condition. Great. So yes, as this group very well knows, we are dealing with the entire lifespan. All right, and so now before I dive in, your initial thoughts. So where I'm going to be focusing today is educational opportunities for the primary care provider, for the most part. So where have you, in your experience, seen that primary care providers need to understand or do things as it comes to genetics? Where is the current gaps where are the current gaps that you are seeing as genetics tries to compete with so many competing priorities for primary care? Assess risk, when to refer, when they can order genetic testing and when to refer, identification, hereditary disease, and then follow-up management. Great. Wonderful. So I think we're going to cover a lot of these. Cultural responsiveness. Absolutely. Wonderful. Okay. So keep your thoughts coming, and I will check in. So we're going to use Jeremy to consider the different roles genetics has in clinical care throughout the lifespan, and to highlight some areas to watch and some areas where we have developed education. So Jeremy is a healthy baby boy, born to, as far as they know, healthy parents. Pregnancy was uneventful, and he has one older sister who's doing well. So let's start here at the beginning, even before the beginning. So preconceptual and prenatal periods through infancy. So where has genetics come into play for Jeremy at this early stage? So many of the early exposures to genetics focus on identifying individuals with rare conditions to facilitate parental decision making, provide opportunity for intervention or treatment, or anticipate issues that they may be dealing with in the future. So let's just talk about these icons a bit. So we have the DNA is supposed to represent where there's genetic testing for a specific or a combination of specific variants or genes. Chromosome for the broader look at chromosomal abnormalities, and then family history, where what we're really thinking about more is taking and assessing a family history. So, so in preconception, the parents had carrier screening for a panel of rare recessive conditions. In the prenatal period, Jeremy's mother had testing for Down syndrome and other chromosomal conditions. Now, as many on this call will know, there are many different technologies and testing approaches now. One of the newer ones, and I probably need to stop using the word newer pretty soon because it's been around for a while, is non-invasive prenatal testing or screening, so NIPT or NIPS. And we're going to dig into a couple of these a little more. So then, as when he was born, he had routine newborn screening. Also, as again, this group will know, to the commonly known as the heel prick or PKU test, but in fact tests for quite a number more conditions. I think the last I saw was 31 core conditions, but I think that has changed as well. And depending on your state, some additional ones. So he gets through the newborn period, or he is born, and then at his first pediatric appointment, his parents fill out a comprehensive family history questionnaire, which the provider uses to target some of the initial risk assessment and counseling. So in Jeremy's case, his older sister has eczema and seasonal allergies, and so looking at this family history, the primary care provider uses that to further encourage breastfeeding to reduce the chance of a related condition in Jeremy, for example. So that's the use, showing the use of just using that in very important family history information. So let's dig a little bit deeper into one of these. So this non-invasive prenatal screening. So it's a test to screen for chromosomal abnormalities. Unlike amniocentesis and chorionic villus sampling, which requires the direct sampling of the placenta or amniotic fluid, NIPT takes advantage of small pieces of the placental DNA that enter the mother's bloodstream. And so then those fragments can be isolated out and analyzed. And this happens at no risk to the fetus, to the pregnancy, and it can be done anytime after 9 or 10 weeks. So this is an area where there has been a lot of development, a lot of dissemination of this technology and this testing, and it's currently, in fact, the guidelines support this type of testing for all women. For a while, it was just high risk for women with high risk pregnancies, but now the recommendation is to offer to all women. And then for those that have a positive result on NIPT, diagnostic testing is recommended to discuss. So now there is some, with the further dissemination of NIPT, it is considered a screening test, but there's concern that patients don't fully understand that it is not a diagnostic test, and may use that misunderstanding not to consider further diagnostic testing. So there's a real counseling issue involved when we talk about NIPT. And as many of you may have seen in just the national in the press, some patients are also seeing this as a gender test, with their primary interest in finding out the sex of their fetus earlier than they can see by ultrasound. And that raises a whole lot of different types of concerns having to do with, everything from being very surprised if they get back information other than, the gender, and then their gender identity issues, all sorts of things. So there are definitely, it has been as the dissemination of this technology has grown, other issues have arisen. But the technology here, the use of cell-free DNA, has many potential uses, both within the prenatal setting as well as in other settings, such as cancer detection, transplant rejection, traumatic brain injury, detecting traumatic brain injury, those types of things. So these are things that, you know, have initially really been disseminated through prenatal, but has the potential of really impacting a future Jeremy's life in many other ways. So we have a couple of modules. So both of these are designed to be 30-minute modules. They're case-based, they're not talking heads, and they're available. I'll have a list of all of the resources at the end, but this is the short URL where you can get these. And these are part of our Precision Medicine for Your Practice program. So Jeremy has made it through infancy with no problems, but lots of interactions with genetics. Now he's on to childhood and adolescence. So what potential role does genetics have at this stage? So genetics here provides an opportunity for early intervention. So his primary care provider watches for persistent health, behavior, and/or developmental concerns to assess whether Jeremy needs additional workup or intervention or referral to a specialist. The primary care knows that genetic testing might be helpful to uncover the cause of any issues that may be presenting themselves. And in order to help the primary care provider and the family identify interventions that can facilitate the best support for Jeremy. In Jeremy's case, there are no persistent concerns, and the PCP does not feel that any type of referral to a specialist is needed. As he continues to grow, at 13 years old, the primary care provider updates Jeremy's family history and notes that there have been a couple of adult relatives on his mother's side that have been diagnosed with cancer recently. So given looking at that whole family history, she counsels the family on hereditary cancer risks. And suggests that his mother might want to follow up with her primary care provider to assess whether further workup and potentially testing might be needed to assess her risk and potentially Jeremy's as well. And then as he gets towards college, as he's starting to enter college, Jeremy plans to play basketball at a small Division I college. And as part of his eligibility physical, it is recommended that he document his sickle cell trait status. So again, Jeremy in this time period is seeing a lot of different interactions with genetics. Let's dig a little deeper into the identifying risk for adult conditions during childhood. So as everybody knows, family history information is really can be very powerful and can in fact be the best way to determine who should get further workup or on to genetic testing. And it often changes more frequently than clinicians ask about it in a way that they're really assessing the family history and really updating. And we can at some point talk about all of the complications with electronic health records and things that make that more difficult to do. But the reality is that truly assessing the family history over time can help to identify patterns that come to light in a child as their parents and their parents' siblings get older and may begin to develop illnesses or receive new diagnoses. And so while many conditions that are diagnosed in adulthood don't require intervention during childhood or adolescence, there are a few where screening could start during this time period, making that family history information really powerful. So for individuals and families who may be at increased genetic risk for disease, genetic testing may or may not be the best option for a child or adolescent. As everybody here knows, genetic information cannot be unlearned once it's available. So these are some of the considerations about, thinking about when is genetic testing, should genetic testing be considered? Would there be an impact on current medical management? The timing of the onset of the disease, is this something likely to happen during childhood? Availability of risk reduction strategies, and on an individual basis, what is the capacity of that child or adolescent to truly engage in the decision-making process? So for considerations of the next step, regardless of the condition, primary care providers are in a key position to identify individuals who would benefit from referral to a specialist, and especially to encourage families to follow through with that recommended referral. Helping them understand why and in what ways a specialist can help. Is it further evaluation of the patient or the family, considering what additional workup and testing might be needed, providing guidance about what they might expect during the visit, and emphasizing the importance of following through with a referral. We know from studies that have been done that primary care's the way the primary care talks about a referral can be sort of the linchpin about whether somebody actually follows through or not. So making sure that the primary care providers know what the family is in for, and can communicate that effectively can be a very powerful role that they have. So we have a few resources that address some of the issues that we've talked about with regards to Jeremy and this time point. So, genetic testing in pediatric neurology, exome testing for diagnosis, and then we have a whole suite of 11 modules that are shorter, that are 15 minutes each, on identifying and managing hereditary cancer risk. And those are all designed for the primary care provider. So really focusing on some of the things that came up in your comments around what do primary care providers need to know. And so getting into adults, what potential role does genetics have at this stage? So there are a number of different things. So, Jeremy and his wife are dealing with infertility, have workups that involve both chromosomal changes, as well as carrier screening, preconception carrier screening for hundreds of rare conditions. There is a point in time where Jeremy's dealing with insomnia, and so talks with his PCP about potentially wanting a sleeping pill or a sleeping aid. And the PCP looks at his family history and says, there's a lot of addiction in your family. Maybe we should try some other things first, just as a caution. So again, bringing in that family history. He also decides in his 40s to try some direct-to-consumer genetic testing or consumer genetics. And I imagine quite a number of people on this call have probably engaged with that as well. He also follows up on the cancer risk assessment information that was revealed during childhood, which at that time was not found to affect him, but the family history continues to change. So this is a poll we're not going to do. And we'll just go forward and talk a little bit about the direct-to-consumer testing or consumer genomic testing. And like I said, many people at this stage have had this type of testing, and it's changed significantly since it was first introduced. And I think I know that early on, primary care providers were very concerned about this. Were very concerned about this information coming into their offices and knowing what to do with it. And now we're seeing a whole range of consumer genomic testing, everything from those that are medically actionable and those include direct to consumer, carrier screening. In fact, so this is testing that is done without a clinician having to order it, although there may be, in some cases, a clinician at the lab signing off on the results, and also providing the lab itself or the company itself might provide access to genetic counselors and others, so that the person ordering the test, the individual might be able to help get some help with interpretation. Pharmacogenomic testing, medically actionable, and in some cases, some rare conditions as well, or genetic conditions. There are also tests that look for things that we consider maybe uncertain clinical significance. And these are things like the connection between different diets and risk for disease, some of the common diseases. And then, of course, there are also still the recreational, attached or unattached earlobes. there have been companies that have, matched your, genetic profile to the type of wine you would prefer. So there really is a whole range. But it has, and then there are also some companies that tie these results to products that they sell, and that has been true historically more in the sort of nutritional supplement area. And so all of these companies still exist. It's the FDA has come in and kind of put the hammer down on certain types of testing, but these are all still available. And of course, there's also the whole ancestry testing as well, which would be an interesting thing to talk about as a whole separate topic. And how do we use, as clinicians, and as family, as individuals, how do we use that information in thinking about, our own potential disease risk? We do have a module, again, in our precision medicine for your practice series on genomic testing for the healthy individual that goes through some of the different types of this direct-to-consumer or consumer genomic testing, and what the implications are, and what this range of conditions are tested for. And then this is our suite of educational for the primary care provider on hereditary cancer. And then moving on to Jeremy's later adulthood, hasn't genetics done its job already? So in what ways can it inform senior health? So here we're looking at opportunities. Not only certainly can inform relatives' health as new diagnoses happen, but can inform the individual's diagnosis and management. So, for example, years later, Jeremy is diagnosed with cutaneous melanoma. As part of his management, he is tested for BRAF to help guide his treatment. He also, there's a dementia examination looking at family history to assess that. And then as chronic conditions catch up with him, his primary care provider considers whether genetic information in the form of pharmacogenomics can help determine best dosing or choice of medication. So when it comes to tumor testing, it can direct treatment choice. So tumor testing has become the standard of care in certain situations and certain cancer types. Involves looking at the genomic makeup of the tumor to provide information about prognosis and to inform treatment choices. Is there a targeted treatment, a treatment that targets a specific genomic change that might be more effective or might be an option for individuals? This type of testing is except in certain situations like some melanoma, non-small cell lung cancer. Some of the broader tests are being used primarily in the setting of advanced or metastatic cancer, but that is likely to change over time as well as the evidence base grows. And so this is definitely an area where genomics, sort of in that broader sense, because we're dealing with a different genome than what we were born with, can really impact health and medical decision making. And this is just to say, this idea of looking at the genomics of others, we've all become very familiar with that with COVID over the past couple of years, and knowing exactly what variants are coming through, and understanding the importance of that as it has to do with our own health. But there are also things like the microbiome, which is the bacteria and other organisms living in a symbiotic, in a mutually beneficial, in many cases, relationship with humans. And so changing the microbiome, changing that collection of bacteria that are living in our gut can change our overall health as well. Things like Crohn's disease and allergies have been associated in some cases with changes in the microbiome. And then, of course, there's pharmacogenomics, which can inform dosing and choices for certain medications. So there are certain drugs that have strong evidence to support pharmacogenomic testing, but it's definitely not across the board. There are many other things that impact how an individual responds to a particular drug. And so this is, as is all case with all genetics, this is definitely a case where things are working together, and understanding just the genetics may not tell us the whole story or predict accurately how somebody is going to respond. And then there's also, pharmacogenomics also brings up the concern, as do many of these other genomic tests, is that the variance between people of different ancestries may be quite variable. And so what are we testing, and what information may we not have, depending on the population that we're testing. And so we do have, we have a relatively recently released module on pharmacogenomic testing. And then we have actually a whole suite of resources, not just modules, but other things on precision oncology. So focusing in on that tumor genetics and genomics, how it, what can we tell about germline genomics from testing the tumor as well. So there's a whole suite there. This first link is for these two modules, and then the second link is the list of all of our precision oncology resources. So that was a whirlwind through Jeremy's life. So to summarize, genetics has roles throughout it. In particular, you can see that rare single gene disorders were considered at all stages, as well as family history. Chromosomal abnormalities and considering the impact of other genomes have had repeat appearances. So it's only a snapshot, but hopefully demonstrates the integration of genetics throughout a patient's lifetime. And if we begin to look forward, what about the next generation? What's coming down the pike? There have been some NIH supported studies in the recent past that have looked at whole genome sequencing in the newborn period. What can that, what are the ethical, legal, and social issues? What are the, health considerations? What can we learn from that? Certainly, I think we can anticipate a broader application of genetic testing into different areas as we further understand the connection between genes and disease, and of course, integration of different types of data. How do we begin to put all of these data sources together to understand how genetics being just one part of it, how all of these things begin to impact our lives and our health. So the key points, genomics is relevant now across disciplines and across the lifespan, and that future application will further integration and opportunities to incorporate genetics and genomics into practice.
Get the poopies out.
So that's where so I wanted to leave you here with these are the links that I provided in the session as well. And this first one is just our general page, so you can find lots of information there. I will say that, again, our main mission is to get this information out there. We have a lot of different ways we like to collaborate with groups. We really do have we try to have an inclusive process in terms of incorporating lots of different viewpoints. And in the development of our materials. So if there are specific needs that you see that you have not found effective education for, please let us know. I mean, we will have to find money together, and we don't come with resources too, but we do come with a great interest in identifying the needs that exist and trying to find ways to address them. So I am happy to answer questions, take comments. If anybody knows of wonderful resources out there, we have about 4 minutes until we need to get back to the main session. But happy to continue the conversation.
Thank you so much, Kate. Does anybody have questions? You can either put them in the chat or just unmute yourself. Kate, I'm curious if you have any sense, other than offering the CME and the nursing credits, which is obviously often the most important enticement for kind of the primary care community, are there other strategies that you have found to draw those providers into being interested in the genetics education that you're offering?
That's a great question, Alyssa. And I think, as much as we at this point, that CME, CME in particular, we actually get really good engagement from nurses. we love to teach nurses. They tend to access our materials more readily. But it's almost an expectation that it's there. So it's not so much as an enticement as a detriment if it's not there, I would say.
Yeah.
But I think a couple of things really make huge impacts. This is something we struggle with too. So if anybody else has ideas about how to get people, you can build the best thing ever, but if you can't get them there, what does it matter? You know, patient stories matter hugely. Like that's what they take, that's what they remember. That's why they're coming, because they had a patient who had an issue, and that has what has motivated them. So that involvement, as we were talking earlier today, that co-production, not just of the resource itself, but of the dissemination, I think is really important. And the more that we can tie the education to real patient stories and hear the voices of patients, I think that from some of our work, you know, that's what they remember year after year.
Yeah, well, that's a great point. And you're right, we do oftentimes find the non-genetic specialists that come to us, either the specialists or the primary care, that have had a personal experience with a patient that, you know, something unusual happened, and then sort of sometimes makes them realize that it was probably applicable to a lot of other people that came through the door before them.
Yeah. And I would also just say that, you know, people say they have lots of time and they'd rather have education online, but it's really hard for everybody in their busy lives to actually, if it's online and you can do it anytime, it's hard to carve out that time. So we've actually also found really good engagement, better engagement when we get people in person. And obviously over the last couple of years, that hasn't been an option, but that in-person or hybrid approach, I think also works really well, just because they have to reserve the time to be somewhere. So the audience might be smaller, but the engagement is greater.
Yeah. And have you been able to get kind of healthcare systems to bring you guys in to do that, or who invites you into the space to do that in-person work?
So that's one of the ways we're limited. So we actually have worked with a number of public health departments that have had funding through a variety of mechanisms. And to do, we've done a day-long hybrid course on hereditary cancer for primary care providers, and it's a combination of we have a standardized patient-provider interaction that happens live. We have a lot of interactive peer-to-peer discussion, and so there we've had folks reach out to us, the Department of Public Health in Connecticut, in Michigan. A health system actually as well. So it's one of the ways we're limited because we're not connected to a healthcare system, but it's definitely one of the things that we're really, that's because we get the best evaluation data there too.
Mm-hmm. Absolutely. I know we only have a minute left, but Carrie had a question about whether you think that primary care, that people that haven't had the personal experience still benefit from hearing a patient story from somebody else.
Absolutely. Absolutely. I mean, we try to get a video in front of them, market it with a video, like, you know, anything that reminds people and makes that personal hook, like, right, this does matter, because we all know it matters, but when you hear it from the words of somebody who's actually going through it, I think the impact is so much greater.